Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspective and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. So I'm Rahul Shah. You all know me. I'm thrilled to be here with Gene Brown. Frankly, I have a knack of inviting myself to visit offices, but Gene invited me here. And he said, why don't you come down to Charleston to see our practice, our community, our state society, which is very active, and I have a lot to learn. I start with gratitude. Thank you for spending the day with me, picking me up at the airport, and really thank you for your service to the Academy.
Well, thank you. We're thrilled to have you as a guest, and I think it's really important that you see what's going on out here in private practices across America, and I think it'll give us all a better perspective of where we're going as a specialty and the kind of challenges that we face.
Yeah, absolutely. Tell me a little bit about your journey, and I try to keep these within the attention span of folks, so if I interrupt you with questions or move it along, I apologize, but tell me, where'd you grow up?
I grew up in rural North Carolina, hog farmers, tobacco fields.
Wow. I
grew up in a town of 300 people, one blinking light.
Wow, what did your folks do?
My dad was a pharmacist. It was a one doctor, one pharmacy town, and he caught people from around the town. The town was tiny.
Yeah.
It's all agricultural.
So I was stunned to know that you are a pharmacist.
Yes, I am.
So take me, how did you get there to here and go back to Dad?
I followed in my dad's footsteps. Mm-hmm. It was a strong influence. I kind of grew up working in the store from when I was knee high.
Yeah,
I would count M&Ms on the tray counter.
Gene's dad taught him at a young age to count real medications, and that was an inspiration for you to get into pharmacy.
It was the way my dad did it. He was very good with patients, and in a small town, a pharmacist is kind of like a physician, and they get asked lots of questions by patients all day, and they have the whole over-the-counter product section to prescribe to patients, and it was a strong influence.
Is your father still around?
He is, and he still works a little bit in pharmacy.
Wow. In your pharmacy down here? You employ him?
Yes, in some capacities.
Really? I didn't even know that.
Yep.
That's amazing.
Yeah.
That's so cool. Well, we're going to tell everybody what we're talking about. So, grew up in a small town of 300, influence as a pharmacist, then you went to school.
Correct.
Okay. Tell us about that. Where'd you go?
I went to UNC Chapel Hill.
Okay.
And I missed Michael Jordan's tenure by 1 year. And I went through pharmacy school.
Okay.
And was planning to get my MBA. Took the GMATs, was on that path. I was going to go back and open up drugstores with my dad. And there was just a lot of pressure that's when Walmart and CVS were growing and expanding. And pharmacy really got commoditized, during that era. My dad was pushing me, and it took me
a while. This is mid-80s?
Yeah, this was 89, 90.
Yeah.
So in the last semester of pharmacy school, we do rotations, and my first day of my first rotation, I met a pharmacist who said, why don't you go spend a couple days with this physician? And from that point on, it's like it was a physician
So it was a 5-year program
rotation,
or 4-year?
5-year program.
So end of that, you got to spend time with the physician?
The last semester. So I did a lot of observation with different types of physicians, and I kind of got tractor beamed into medicine. Now, I'd taken the right prerequisites. I was pre-med at some point along the way, but really wasn't planning to go to med school, and then I just got sucked in.
Where'd you do your med school?
I went to East Carolina.
Of course,
University.
ECU, Brody School.
Yeah, exactly.
That's fantastic. And then residency?
Did residency here in Charleston, MUSC.
Okay, so then from North Carolina, you went south.
Correct.
Big journey. You went
3 hours.
3 hours.
It wasn't just horse and buggy,
We're going to talk a little bit about when you had the OPPS, Otolaryngology Private Practice section, and there was an awesome panel. I think you were on with Albert Marotti talking about how we have trainees see the spectrum of care. So when you were at MUSC, were your rotations all academic?
We did 6 months at the Navy Hospital.
Okay. Yeah.
And we did 2 months with a plastic surgeon because that was our facial plastics exposure.
Okay. Please have your coffee because I'll keep going.
I know. I've seen your podcast before.
Yeah. Okay, it's your podcast. It's Voices of Otolaryngology. Without you all, I'm nothing.
I've seen your podcast before. I know this is your podcast.
Touche. I trained at Tufts Medical Center, and as I told you, we spent 18 months rotating with private practitioners in Rhode Island and South Boston, and it was transformational. And I know that's something you've talked a little bit about that. Could you talk a little bit about that with our colleagues? Why do you think it's important that we have rotations that are in the spectrum of what we do as otolaryngologists?
Well, one of my main interests is in terms of the otolaryngology workforce. And I feel like it's important that as a specialty, we have balance between generalist and subspecialist, and we provide access points and different mentors, for different trainees. And I think that trainees need to have different experiences and exposures along the way to find what their love and passion is. And I know for me, that's general otolaryngology. I can't imagine a better career choice for me in a private practice. It just helped me to accomplish everything I wanted to in terms of patient care, gave me chances to pursue some entrepreneurial interest, and to be a figure within a community. Mm-hmm. Being a general otolaryngologist in private practice, most of my patients know me, or are their family members or people that I've treated, or know someone who told them to come see me. And so you become really cemented in the community. So where I'm going with this is that I felt like there was a shortcoming in programs that do not have private practice exposure. And I feel like that the young physicians aren't exposed to the full gamut of what otolaryngologists do and can do. And my concern was that it was skewing the workforce in some ways. When socioeconomic surveys show that 75% of chief residents want to pursue a fellowship, that makes me really pause and think, is that good for the specialty? Is that good for the patients? Does it provide the right access points? I think it definitely provides excellent care. The more training and the more precision and technology that we're able to produce and offer patients, that's great. But does that allow us to meet the needs of the population and the communities? So that's a big part of my interest, and was a big part of things that we spoke about in the private practice section. It also is a big part of what we talk about in our crucial conversations meeting at the academy. We've done for the last 2 years, we've done an hour and a half conference with guests speaking about these kind of issues and how it affects the workforce. So one of the things that I'm proudest of here in Charleston is that we have seeded a private practice rotation within my practice.
That's awesome.
Dr. Labady's the new chairman at MUSC, has been very collaborative in helping me to develop this, and Ted Myers, a program director there, and it's been very successful and well received. So that's a long answer to your short question, but there was a lot of meat there.
Yeah. Thank you, Dr. Labady and Dr. Myers, for buying into that vision. And do you really need me for this podcast? I mean, you just had a nice soliloquy there for 8 minutes. I think I can just walk out and you can do it on your own. You don't need me.
No, you're a natural at this. I've seen you. You're like a talk show host.
Yeah.
You keep going.
Dr. Brown, I took a lot of notes here, and I want to go step by step.
Can you read those?
Can I read those? Yes, sir. Okay. Pediatric otolaryngologist. I don't need an EMR to read notes. What does a week look like for you in terms of patients? What does your practice look like as a general otolaryngologist? The audience for these podcasts are residents, trainees, and I want to inspire them. What does a week look like for you?
Now, my role is a little bit different because I'm part clinical and also
absolutely, but how about your clinical part? Yeah.
But let me say, before I became more administrative, a typical day for a general otolaryngologist, a typical week, is a 4.5 day week, and usually try to reserve Friday afternoon for golf. Yeah. That's usually 1 day in the OR, usually an outpatient center ambulatory day, and another that leaves 3.5 days in the clinic seeing patients. Usually a clinic day is about 36 patients, 18 in the morning, 18 in the afternoon, 7 new patients, 11 follow-up patients, and it's just seeing a wide gamut of
and
diversity.
You see it all?
Yeah, you see it every day.
You do?
Yeah.
You've not focused
newborns,
on within. Oh, really?
Newborn children. We see old patients. We see young adults. Every age.
Yeah, I have it easy. As a fellowship trained, I know what I'm going to see every day. I mean, how do you keep up? What do you read? I'm being serious. It doesn't need to be academy promotional, but really, how do you stay on top of geriatric, voice, all the parts of our specialty?
It takes a commitment, to continuing education, reading journals, going to meetings, and learning from your partners. I've got 13 partners here in Charleston, and we interact a lot in clinic and give each other second opinions and curbside each other all the time.
Well, you're blessed, though, to have that big group.
Correct. Yeah. Indeed.
So that's a week of clinical for you, which I appreciate. I just wanted some of our listeners to hear that. I have been with you, I don't know what time it is, my phone's recording. I've been here with you a couple hours. 4 times, even from the airport, you've mentioned the workforce study. Is it worth Academy members reviewing? Can you talk a little bit about that workforce study? I found it phenomenal.
Yeah.
As a member, I found it phenomenal when I interviewed for the job. And for me, I look at it probably 2-3 times a month. And it looks like you're really quoting it. I mean, talk a little bit about that workforce study if you think it's worth our while to look at as members.
I think that the workforce study offers a real-time look at the specialty and allows people to see more of their blind spots. I've seen a lot of academicians just blown away at some of the data in there.
Yeah, myself included. It was stunning.
Resident feedback has been robust in terms of...
So our residents have used it. Yeah, that's great.
That they're seeing and learning from there. And it's very seldom you go to a meeting where nearly every speaker doesn't pull some chart from that.
Yeah, it's awesome.
Yeah, shout out to A.J. Tompkins. He really spearheaded that. He owns the workforce.
Yes.
He had these ideas when he was very young, brought them to one of our OASIS meetings.
And help people. What does OASIS stand for?
OASIS was a clinically integrated network that we organized. And it did 3 things. There was a GPO, a group purchasing organization associated with that, a clinically integrated network, which connected members electronically to share information. And then we had an annual meeting. And the annual meeting kind of became a gathering place for private practice leaders and academy leaders. And A.J. Tompkins, before anybody knew who A.J. was, he organized a workforce lecture and presented it at OASIS and blew everybody away. And shortly thereafter, Jim Denneny had him organized with the task force. And
was this pre-COVID or right?
Yeah, it was right there.
2020, 2021?
1920, in that range. I can't remember the exact year.
And the workforce study came out 2023? What are we now? We're January 2025, yeah.
Well, when was the first one? It was like 22 and
and then
24.
The most recent, yeah.
Yeah.
Okay.
I think they're 2 years apart.
What is your biggest take home if you could give a highlight to that workforce study? I mean, it's 50 plus pages long, awesome graphs and data, and you quote it all the time.
What is the biggest take home
for
from that study to me?
For you, yeah. Everyone looks at it differently.
When I look at that study, I really want to know that after going through all the training and committing all the hours into one's practice and developing the skills that are needed to do this job, I really enjoy the graphs that are reflections of an otolaryngologist's happiness in his career.
Mm-hmm.
Fulfillment,
wellness.
Fulfillment and wellness and, would you do it again kind of questions. It really is gut-wrenching for me to see people that travel this road and then aren't happy at the end of it.
Yeah. That's why I took this job, Gene.
Yeah.
I'm serious. And you interviewed me. I think you were on the search committee.
I was.
You were,
I was.
Yeah.
That's why I'm sitting in this chair also. Seriously.
Yeah, I appreciate that.
Advocates for our physicians in our specialty. I think that's a common bond amongst most of us.
Exactly. And I took the job. If we can drive wellness for otolaryngologists, we would have done something. I mean, that's why you're president-elect, and that's
Correct.
why I've done my career pivot.
Agree.
Interesting, and this is a sidebar. I was going to get to it later, but I think it's a natural segue. Right now, your practice is huge. There's a shell that people can join to be otolaryngologists within you all, but I'd say there are 27 otolaryngologists within your tax ID number. Is that fine to say?
We have 27 now. We have 4 coming in the summer.
Yeah, thank you.
Yeah.
And I was with one of your, if I may say, founding partners, perhaps. You were residents together,
yes.
right?
Ed McNellis. Mm-hmm.
Please say it again.
Ed McNellis.
Ed McNellis. And so you both were residents together, and I asked you a question. And I said, what's been your turnover? How many people, other than retirement and passing, how many people have left? And you both struggled, right?
Yeah, probably 1 or 2 over 25 years.
Yeah. And what I noticed around this practice, surrounding me here in the back is Stuffy, which is their mascot. Stuffy's here, and here's Stuffy. And I'm not making fun of anything, but it's really interesting. We talk about having fun at work, and Stuffy is recognized all over the city on sports logos and brand. Talk about wellness at work. I mean, there's something you all are doing right if your turnover is exceptionally low. You have 350 employees.
Yeah.
And your turnover there is also low, I know. Why do people stay with you all?
It's always been a family environment.
I mean, your CT tech's been here 20 plus years.
Yeah. It's always been a family environment. I think that the employees that have been here for that long take a lot of pride in the growth and the things that they've accomplished over that ride. And I think that no one takes themselves too seriously in that regard. I think that everyone treats each other with mutual respect, regardless of job title or function. And it's just a culture that's been created, and it's easy to come into this culture and be successful and be comfortable, which perpetuates the culture.
I'd say culture starts at the top, so kudos to you and your prior leadership for engendering that. That turnover rate's staggeringly low.
Thank you.
Yeah, and I wonder if Stuffy has something to do with it. What is up with Stuffy?
He absolutely does.
And why Stuffy a nose? How about the ears? How about the throat?
Yeah.
Come on, I'm going to go there. And why Stuffy look? Stuffy's not pediatric, doesn't reflect our specialty. Everyone criticizes Stuffy, but it's amazing. What's the story behind?
Hero.
Yeah, tell us about Stuffy. This is Stuffy.
Stuffy was the creation of a marketing blitz that we had.
When was this? When did it start?
It was, 2008-ish, somewhere in that range.
Okay.
And Stuffy, was so popular from the inception that he just took a life of his own. He's been on television.
I mean, you could have called him anything. Mary's, Septum, but you called him Stuffy.
Well, that was an attempt to reach patients who can't breathe well through their nose.
Yeah.
But it also was a cute nickname that people related to. We have, the baseball teams that have professional mascots.
Yeah.
There are people that make those mascots.
Yeah.
They made a Stuffy outfit. You had a chance to meet Stuffy today.
I did, yeah.
So Stuffy is a real person.
And I got to see kids in your office, and they love that. It's interesting, right?
Yes, he's been on television. He's been on billboards. And
has it helped you as a
practice? He goes to the minor league baseball games and makes appearances.
So it drives ROI, you think? Sure. Brand recognition.
Oh, for sure.
Brand recognition.
People relate to him.
We were just talking about Stuffy. We're talking about brand management, and kudos to you all. There's many ways. I could debate this all day long. Where's the caduceus? Where's the logo? It works. It works for you all. It's been great. Tell me about your practice setup here. You're the president and CEO of the group, 27 otolaryngologists, about 18 to 20 audiologists, similar number of advanced practice providers, 350 employees. How many offices? And talk a little bit about your structure, if you may, and what you can tell us about the relationships that other practices have with you all, and surgery centers, everything.
Yeah. So, the heart of our practice is in Charleston.
Okay.
That's where we started and have grown. And we have 8 offices around the Charleston area.
Okay.
In the middle of all those offices, we have an ambulatory surgery center, which is kind of the lifeline of the practice. And that creates a lot of synergies with partners. And so these physicians work in this community. A few years ago, we realized that there was a need with other practices in our state that may be small and independent and might be struggling, maybe didn't have the infrastructure or the talent level within their offices to be successful, to negotiate well with payers, and just to operate a practice successfully. So we created a type of association where practices could step into our shell.
What year was that?
This was 2016, 2017.
Thank you. Yep.
And, we really provided a lot of what people would call the MSO or management service organization type services. But we bring small groups into, we don't buy groups and we don't try to overly control them, but we bring them in and we plug them into what we're doing. We let them access our contracts and our staff and our technology, and we grow them. And we grow their success. And it's been successful. I mean, we're a small state, so we only have so many opportunities, but we've been successful in outreaching to 3 or 4 or 5 groups over the state, and it's helped us to grow outside of this core in Charleston. It's created some leverage for us, with payers and with
it helps the
other entities.
Otolaryngologists.
It absolutely does. It improves quality of life.
And if not you, somebody else. Right? If it wasn't you, some other MSO would have come in, right? They would have sought...
Probably so.
Of course.
I mean, that's what we're seeing across the country.
Right. So it's awesome that you all are helping our own otolaryngologists.
Correct.
And that happened organically. It was an idea. You just saw an opportunity in the marketplace, or they came asking for help. What?
No, we saw it as an opportunity, a chance to, it's a chance to lift other otolaryngologists. It also creates some revenue from their practices that offsets,
of course,
the significant expense
costs
of this machine.
Exactly.
So there's a win-win there. For anything to be successful in medicine, you have to be creating a win on both sides of the equation.
Yeah.
And if you can't, then you don't have the trust. You're not going to have long relationships, and your success will be limited.
Yeah. I have started talking a lot in the bulletin articles about evolution of practices. Gavin Setson, Mark Dubin have mentioned that to me. Some other folks that I'm talking to. It's interesting, your evolution. So started, you had your founding 4, and then it looks like there was a evolution in 2015 to 17 where you increased. Take me from the founding 4 to 2015, 17, if you can kind of remember that evolution. What strikes me here is people look and they say, wait a minute, how do you get to 27 otolaryngologists, 20 audiologists, 20 APPs, 8 practices, 2 ASCs, pharmacy, etc.? And it can actually be fast. It doesn't have to be so slow. From 2017, 18, you were actually pretty quick, and you had COVID in there. But talk to me about kind of the earlier years.
Well, I think that our success, the backbone of our success is that we all split income. Splitting income creates alignment, it creates cohesion, makes decisions easy, and if something can be done to improve the group or the success of the group, then everybody's on board with doing it. And we achieved our growth organically, which means that we successively would hire new residents into our practice, and that created people that were willing to follow the model. We spent time educating them on the front end. They stepped in. It was what they thought it would be, and they stayed. They were happy. And we've always tried to be fair, to younger physicians and create opportunities for other physicians within the group. This organic growth led to expansion into different communities, development of ASCs. We are pretty flush with ancillary services. We do imaging in each office.
But you build those up. You just didn't walk into them.
Right. I mean, it's a purposeful
You've made some mistakes.
commitment.
I'm sure you have. Yeah.
Of course we have.
Yeah.
But it's just been a stepwise progression with a willingness of our partners to reinvest in the practice and a desire for people to come in.
I read Harvard Business Review quite a bit. I reread it and reread it. Sometimes it takes me 3 or 4 times to get an article. I don't have a problem admitting that. There's a great article this month when they talk about business growth and how for teams to thrive, you need to all share equally. And it's interesting. You just said that.
Oh, that's interesting.
You just said that. I mean, you innately kind of have seen that work for you all.
I agree. I mean, when your organization is weakened, when one person might be making twice as much money as another person.
Maybe over-operating, overutilizing.
And it encourages that, overutilization.
Yeah, sure.
So we've always
and then you get into overhead problems, right? How do you allocate overhead if somebody's using...
Absolutely. And all those things create tension.
Yes.
And take away from the alliance together.
I was shocked, and it's okay to use this word, when I walked into your office and I saw a pharmacy. And this wasn't a CVS or Walgreens. Can you tell everyone about the pharmacy? Pretty cool. And then do you know if any other otolaryngology practices have that?
Not that I know of, but I grew up in a pharmacy.
Well, you're a pharmacist.
Yeah, I did.
Yeah.
And so was Ed McNellis. So both of us were
really?
pharmacists. Yes.
And remember, folks, do you mind telling them about Ed again?
Ed was my co-resident.
Your chief resident.
My chief resident.
And he was a pharmacist too.
Yeah.
And now this is when you all were at MUSC. Residency. MUSC,
correct.
Yeah, okay. And he had his pharmacy before then.
Correct.
So interesting. So putting a pharmacy and compounding pharmacy is not for everybody.
No.
But tell us about how it works for your practice. I think the Porson example is awesome.
Well, the advantage of having the pharmacy, it offers convenience, but what we have that most practices don't is we have access to all the specialty products.
Yeah.
I don't have to use a mail order pharmacy to dispense mupirocin capsules to mix in your Neilmed rinse bottle.
And the patients get it that day.
Right. If you want beta histine, you can walk out of here on beta histine.
Yes, I love it.
Where are you going to get beta histine otherwise, other than mail order?
Yeah.
But, just a number of niche products like that. We compound our own eardrops because we can sell them so much cheaper. Retail pharmacies,
of course,
they jack the price up too high on those. So we are able to do that for patients and create convenience. And we also dabble in, some things that we read about and have innovative compounds.
Awesome.
We were making Theophylline nasal spray far before
that's so cool.
It was launched for clinical trials a couple of years ago.
Do you maintain your pharmacy certification?
I
don't know what it means.
I do not.
But do you ever go behind the counter and you just count meds again?
When I go back there, they roll me back out.
They roll me
afraid I'll mess something up.
Yeah, they don't even let you count M&Ms.
No more
That
M&Ms.
is awesome. Do you ever envision sometimes life goes full circle, especially in healthcare? We do things 30 years and we bring them back up. Do you think that might be the future, where we actually have pharmacies in big practices like yours?
No.
You don't think so? You think it takes a very unique...
It's not...
it's very cool.
It is a patient service.
It's amazing.
And it brands us as being on the cutting edge. And it's great for patients.
Yes.
Economically, it is not great.
Really?
It is not.
I was gonna,
I know. So
I had my checkbook to join as a partner. Oh, I thought it'd be lucrative ancillary.
No,
that's fine.
It's a challenge to break even at the end of the year. It really is.
Okay, I didn't want to get into your economic model, but that's shocking.
It is just
so you're actually doing it for patients.
Yeah.
Okay. When I hear compounding pharmacy, I see a lot of dollar signs. So I appreciate you for doing that. Sorry, I didn't realize that.
No, it really does. It boosts quality of care too.
Clearly,
we're really able to do some cool things.
But I thought there's tons of ancillary coming from there. I didn't realize that it barely breaks even.
Yeah, we you know how you put the antibiotics in the gel and you can squirt it into dependent sinuses. We make all that stuff. It's so much fun.
Yeah, but it's I didn't realize it was break even. So thank you for that. That's pretty cool that you offer that. Driving over from the airport, and we might name the podcast this, everybody, because I think it's going to be catchy. Paradox of Urban Generalists. You coined it, and I'm gonna let you quote it. Paradox of Urban Generalist. Talk to me about that.
Yeah, the paradox of the urban generalist.
Yeah.
So, I think this is a term that my partners are tired of me using because I use it every meeting, and really it's a reflection of what I see that's happening in the urban markets.
Okay.
It's a reflection of increasing subspecialization within our specialty.
Yes.
I think
an increasing number of subspecialists.
Correct.
Okay, both of those.
I think that it's an increasing, it's a reflection of increasing technology that subspecialists have available to create better outcomes that may not be offered within a private practice.
Okay.
But the paradox of the urban generalist is that you don't have a practice where you're practicing as big a scope of the specialty.
Okay.
there's more competition for patients. More of the subspecialty patients are pulled away, and you even refer them. I mean, I'm going to refer somebody to a subspecialist who can do something better than I can.
Absolutely,
right?
will. Yes,
absolutely. And then some of the patients, everybody in my practice, I practice in a affluent suburb. Everyone in my zip code has a graduate level degree. Wow. And, many of them, once I help them understand the diagnosis, will seek more expertise.
Absolutely, sure.
Which is good. I think as for consumerism, that's excellent, and for quality of care. So I think that the paradox of the urban generalist is that your practice is going to be a little bit different. And when you read the message boards on the private practice section
on ENT Connect,
you hear lots of people say, "Why are you marketing in Philadelphia? If you would just move out here to my medium-sized market, you don't have to market. There are more patients than you can treat anyway, and you can do any procedure you want to."
Yeah,
and it's true.
True.
It is true.
True.
In a more urban market, your practice is different.
I'm pausing. So the paradox is, as an urban generalist, your scope is reduced.
The scope is reduced. You have a less of a surgical presence.
Yes.
You probably see more ambulatory conditions than a lot of people would like to.
Yes.
A lot of acute infections.
True.
A lot of eustachian tube dysfunction.
Yeah. What's your algorithm for eustachian tube dysfunction as an urban generalist? How do you...
Well, I mean, for me personally, I'm trying to make sure somebody doesn't have infection, driving continued inflammation, and making sure the eustachian tube's open. And for that patient who doesn't have an obvious problem, if they don't have a history of eustachian tube problems, I'm mostly providing reassurance. It's going to get better with time.
I love the historical figures in our field, and we stand on their shoulders. We all do. And I trained in Boston, and Dennis Poe, do you know the name Dennis?
I do.
Yeah, amazing otologist. And when we did our fellowship at Children's Boston, we got to sit next to him and operate with him. And Dennis, I wasn't that good as a surgeon for Dennis, but in my mind I was great. But Dr. Poe's amazing, and as you know, he did a sabbatical to study the eustachian tube. Isn't that amazing?
It is.
For an extended period, and really helped us to understand eustachian tube dysfunction. So we're blessed to have people like that. But
absolutely.
So when we have a paradox of urban generalists, what advice do you give for recruitment? How you're at 27? You said you have 4 coming. 4.
Yes.
So how you're, I don't say you're solving the paradox, but you're working around it. How are you able to recruit?
Well, I think in a practice...
I'm talking about otolaryngologists. I want to get to other kinds of folks later.
No, in a practice my size, you can develop a niche.
Okay.
And if you develop a niche, then your partners will refer you patients. And I think that's an important way to grow your practice within an urban setting.
Okay, cool.
I think that's...
So remaining an urban generalist, you have a niche.
Correct.
Yeah. You introduced me to one of your partners who looks at wellness, well-being.
Yes.
Do you want to give her a shout out?
Yeah, Jessica Lee. She's
Lee.
Awesome. She did additional training.
She's more her podcasts are more popular than mine.
Oh, and mine. Yeah. We'd have to combine.
Yeah. Okay. Let's combine.
We'd still be behind.
Yeah.
She does a lot of integrative and wellness medicine.
So you might refer your patients to her too.
Absolutely.
Yeah. That's pretty cool. Can you talk a little bit about her practice? That might excite some of the next generation to reach out to her.
She looks at your lifestyle, your diet, your habits, your stress, your sleep, your exercise, and she's able to help you make adjustments.
Amazing.
In those basic concepts
to improve your
symptom control.
Can I go see her after this for my sleep apnea,
when
my
she told
nasal
me
obstruction?
About it, when she told me about it, I said, Jessica,
let
me be your patient.
Yeah, I want to be her patient.
Please, I've got a lot of work to be done there.
That is so cool.
It really is. It is.
Awesome.
And there are a handful of ENTs that I know of nationally that are involved in this type of practice. And I think it's really evolving. I think there's a great demand for it. With the public.
You've used words like demand and recruitment, so I'm going to ask you about audiology. I've been about a month and a half on the job, And audiology, it's very tough to recruit audiologists across the country.
Yes.
My understanding, and you've got to correct me, you know this better than I'm learning. My understanding is their waits times are very long for audiologists. We can't get our patients in, and it's scary, actually. Are you feeling that here? Do you see that?
Yes, it is a struggle. I think that the field of audiology is struggling, to keep up its workforce. More audiologists are leaving the field and retiring every year than are graduating into practice.
And it's a tough field. It's not easy.
No, it's not. And I think that, when they took training from 2 years to 4 years, I think it hurt the field. I think it saddled a lot of young graduates with educational debt. Consider all the educational inflation we've seen.
Yeah, well said.
Over the last 10 to 20 years. And it's just a stressful situation for those young professionals. And unfortunately, the statistic is it's pushing a third of them out within 5 years of being in the field.
Wow. So they train double as long, and they're leaving within 5 years. And are you feeling that in Charleston in recruiting?
Within my practices, we have lost a lot of audiologists. It's hard to keep them. We really have taken a proactive
Where are they going,
stance.
Gene?
They're going everywhere. They're going into different fields.
Because they can.
They're leaving the field.
Right.
COVID was a liberator. A lot of people left their fields, and we saw a lot of audiologists leave. It's really trying to create a culture where audiologists take pride in treating patients with hearing loss instead of selling a hearing aid.
Yeah, absolutely.
I think that's a culture you need in your practices. I think that helps them with job fulfillment. But I think it's a real challenge.
Oh, that's unfortunate.
And audiology is so important to the jobs that we do and the quality of care that we provide as otolaryngologists.
Yes.
It's a very impassioned interest, for any otolaryngologist to make sure you have a stable, high-functioning audiology complement in your office.
Yeah, but it's interesting you're feeling that challenge here as well. Yeah. OPPS, could you define that for folks? And you've been working with folks. I'm not going to say their names because I'll forget everybody. You can say those and get into trouble, but OPPS, it's awesome what's come from that group. Define it for our folks.
Well, sometimes I can't even remember all the letters stand for.
Otolaryngology Private Practice Section. There you
go. There was a. So it comes back to OASIS and why we did OASIS.
Okay.
And we were trying to create a platform.
Yeah.
We were trying to create a network, because private practice doctors don't have that.
Okay.
They're disconnected. They struggle in their practice in their town. They don't really have a place where they can come and share ideas, learn from other people, interact.
You know how I know I'm doing a great job, by the way? You're on the executive committee. You employ me. You know that. Let me just plug myself here. Why am I doing a good job?
I've been waiting for this one.
Yeah, it's coming. You pay my salary. I have to be real. The academicians worry that the academy's private practice focused, and the private practitioners worry the academy's, too academic focused. So I know I'm doing the right job.
You're doing great.
Yeah, because I can't keep everyone happy, which is awesome.
Your first 60 days, you've rocked it for 60 days.
Yeah, exactly. Yeah, I'm keeping nobody happy. So go with that, because you're talking about the disenfranchised private practitioner.
Yeah, so, that was something that really struck me. And that was a real strong driver for why we pursued OASIS.
Okay.
And OASIS was kind of a magical thing, because every year it got bigger and more people came. I mean, we'd have people from 23 states come into OASIS. And it got to a point where we reached a critical momentum. And one Saturday, I was on the back porch typing a letter to Jim Donnelly, one that I've considered typing for many years. And I said, Jim, we really need a private practice section for
what year was practices.
This was, oh boy, I'm going to screw this one up.
We're 2025 now.
Probably 20 or 21.
Yeah, COVID, right in the middle of COVID.
Yeah.
Okay, all right.
So I sent my letter and I said, I really think this is something private practice needs. They're disconnected, they're disenfranchised, they don't feel like the academy is supporting them or their efforts or addressing their needs.
Dr. Delaney's amazing. He's had a lot of roles. He's been in academics, he's been in private practice. So interesting, yeah.
So I sent that email that morning, and I went to play golf. And before I could get through the first 9 holes, Jim Delaney says, I've got a phone call. I'm sending you an invite for a Zoom at 4 o'clock today with Ken Yanagasawa. It's when Ken was president. Yeah. And we went through my letter, the 3 of us, and I think that it really, I think everybody connected that there was a need there.
That's fantastic.
And the academy needed that to pull in some members that didn't feel connected.
Okay.
And, that's what the academy does. The academy has a place for everyone. And the academy should be home for otolaryngologists, and that's what we work towards. So I think establishing the private practice section was just another offshoot of the academy in terms of taking care of our own and representing our own. Jim and I did a survey one year. I don't remember when. You're always going to ask me for the date. And we sent it out to all otolaryngologists. And we got about 500 responses.
It's pretty high for a survey.
Yeah. And a lot of the questions were about connectivity, challenges in your practice, recruitment, running your business. And we really got some heartfelt responses. And he and I poured over those responses and those survey results. And, those were some of the cementing themes that helped to seed that interest and cultivate and catalyze that private practice section formation. And then we were lucky to tag the right people into leadership positions like Mark Dubin, one-man show, made the whole thing happen. And a lot of other private practice doctors.
And that Pham is your president now of the private practice section.
Pham, Dave Mellon, who was a long-standing OASIS contributor and lecturer. A lot of strong leaders came in and made that happen. And, I was just very thankful that the leadership at that time was so interested in the needs of those physicians who didn't feel connected.
That's awesome.
And I'm sure there are other people out there now that don't feel connected. And I think it's our job to find them and find a way to tap them in.
You're a president-elect, and I work for you and the members, and I do worry about those folks that are not members, those people who have canceled their membership, right? It's my job to ask, why did they cancel? Why are they not members? Why don't they believe the academy represents them? And there are certain groups that we need to reach out back to, and those groups know who I'm speaking to, and I'm working to make sure we do that.
Well, we're a small specialty, and, it's hard to have a big voice. We all need to stand together. We don't need to be fractured by subspecialization or by job type. We all need to be able to stand together and represent each other's interests and have each other's backs. And I think that's, part of what the academy is. And that's part of the reason I'm active in it.
Yeah, and congratulations for being elected president-elect. I know your term won't start till after the annual meeting, so I think October 13th or something next year. You must be thinking about an agenda, and we were joking around a little bit earlier, and you gave a great quote about agenda. I don't know if you remember what you said, but I said, what is your agenda? And you had a good quote. I think it's important for all of us to know your beliefs.
Yeah. Well, I don't mean to sound corny.
No, but it's true.
When I was drawn into being active in the academy to represent private practice, and the things we were able to accomplish with lots of help from lots of people in the private practice section, really that helped me to accomplish all my personal goals. And really the reason that I've pursued further leadership within the organization was out of a pure interest to help the specialty and to help otolaryngologists to be successful and have meaningful careers and be able to do the things in their practice that they want to do.
Yeah, I'll give you a fist bump for that, because we do this in the podcast. We'll talk about a lot of fist bumping, because that's why I'm here. I felt that I had a very blessed career and achieved what I wanted, and I wanted to serve our specialty. And it's interesting, when we were driving over to your office, we were talking about clinical practice guidelines, expert consensus statements, and how we use them. So the intersection between academics and private, in my mind, are blurred, and they come within the academy umbrella, right? We were just talking about integrating and how we can get more people. You were talking about how we get more people to use our CPGs, right?
Yeah. I think that you're right. I think the challenges between academics and private practice become the same.
Yes.
More so every day.
Yeah, I agree. And I see that the more and more meetings I attend representing academy members. Yeah. So I appreciate the time we've spent together. What take-home message do you give to our otolaryngologists? We can talk about Stuffy. We can talk about MUSC, Charleston. This city's booming. It's really taken off in the last 30 years, right? It's really great to see. You have the voice. You're going to be our president starting October 2025. What message do you want to give us for the next 10 months? What should we be thinking about as otolaryngologists in medicine, wellness? You want to go, is there a verb for Stuffy? Like go stuff it?
Stuffy is not.
I mean, do you have stuffed animals?
Oh, yeah.
No, for real?
Oh, yeah.
I can get a Stuffy stuffed animal?
And we can get.
You're probably going to make me pay for it.
No.
Yeah, I'll go to the pharmacy and buy it.
No, we have lots of giveaways. You're going
to
love it. You can take some home for your kids.
My 16-year-old and 20-year-old would love Stuffy.
Yeah.
What's your message? Is it one of inspiration, hope, excitement? We have a new administration coming.
I think that I think it's easy to get frustrated.
Yeah.
And with all the change in healthcare.
True.
I think that it's very frustrating for people to see what's been going on with CMS and the conversion factor.
Sure.
I think that burnout is real.
Where we still got a cut, despite a cut, and they called it a win.
Exactly.
Right, and that's absurd.
Burnout is real.
Yeah.
I think that the jobs we do are hard.
Mm-hmm.
I think that sometimes our patients expect more than we can deliver.
Absolutely.
And I think it creates, it's a tough job.
Mm.
And I would just remind people, consider why you went into medicine and consider the good that you do and how you can help people, because I think nobody goes in to a 9-year training program to make money or to have individual accomplishments. To get that far, it's usually an altruistic, gravitational pull that you want to help people and make a difference in their lives. And I think that it's important, to keep that focus on the difference you can make in people's lives, and to let your happiness come from there and not from income or from, recognition or other achievements. And I think that's important for us to remember.
We've spent about an hour and a half here. I'm very grateful for your time. Awesome discussion. I want to explain how the Academy works a little bit. There's a board, and then there's an executive committee. The board meets 3 times a year. The executive committee meets every month. We had a meeting last night, and I appreciate you all, but as the EVP CEO, I report to you all and the board who hires and fires me. So frankly, this is your podcast, and I think you're asking for some time to ask me questions, so go ahead.
Yes.
Nobody's done this yet.
I've been
my
watching
13 recordings, so go ahead, boss.
I've been watching you do these podcasts, and I was envious. I wanted to be you.
Yeah.
So this is my chance.
Go on.
No, I just, I had the pleasure. I did not know Rahul before.
Yeah, we didn't know each other.
Before you applied for the CEO job.
Yep.
I'd never met you. I'd never heard of your name.
April 5th was my interview.
You're pretty much a no-name.
Yeah.
No, I'm just joking.
No, we didn't know each other.
But we met, during the search committee exercise.
Yeah.
And I thought you just blew it out of the water.
Oh, thank you for that.
In all your interviews. I thought that everything you said was heartfelt and that you had a great depth and ability to analyze situations and see through them. I just wanted to ask you, you've been here for a couple of months now.
Yeah.
What's it been like? How's it going?
Thank you for asking. These are not planned questions, because if they were, I'd have a better answer. So that's just a caveat. I wake up every day and I run out of the house right to the office in Alexandria, skipping to work. It's a joy. I love it, and I'm thankful for you for taking a chance on me as a healthcare administrator. I'd served in that role. I'd been 18 years at Children's National, rising to the rank of professor of surgery, over 100 articles. I love peer-reviewed scientific literature, but what I love is impacting our members in our specialty, advocating, using data to drive change. I actively curate and believe that our collective voice is very strong. So our social media presence is actually not about me, but we leverage that to drive change. And I'm very conscious of what I post, and I know who follows me and the impact we have. So I love it every day. It's a highlight.
So what have you learned?
Yeah. I've learned.
What did you learn that you just had no insight into? You didn't even know it happened, that this was an issue or an ENT thing?
Well, what I would say, and I want to be careful here because I don't want to show my cards, but scope of practice. Gene, people are coming after us. And it's not just in healthcare. People come after us as physicians. People come after us as surgeons. People come after us as otolaryngologists. If we are not alert, if we're not looking around and building bridges, people are going to go around us and build a bridge. They will go above us. They will go below us. And if we don't extend an olive branch, they will find another way. And when I mean people, there's all types of folks. And it's not just other specialties. It's insurers, it's pharmacies, it's other constituents. And I'm shocked and surprised by that is a big learning of mine. The other learning of mine is how much I learned from practice visits. I've been around the block. I've trained in private practice settings. I've been around, but every time I learn, I'm humbled by what is out there. And for me, it's a joy. My regret is how do I spread that to others? And that's what I try to do with the podcast. That's what I try to do on LinkedIn. Take best practices so we can keep wellness going. I talk about why I took this job. I was on a panel, it was at the annual meeting in Nashville, controversies or where you debate. Great debate.
Yeah.
And I had to take the con side of work-life balance. They just assigned it to me. I was a high school champion for debate, by the way.
I'm not surprised.
Yeah, that's what kids who can't play sports do.
Oh, okay.
All right, public speaking, right? So I couldn't play. I mean, I was good, but not good enough at baseball. And so I sat across one of our otolaryngologists. She's in solo private practice in California. And she says, when the toilet breaks, I have to fix it. When the alarm goes off at 3 a.m, she has to go into her practice. And that really resounded with me. And you had to do that when it was a group of 4. You might not have to do it now, but I'm looking around your office and there's something mentioning flood here, there's telemed, there's in-person meetings. There's a lot to run a practice. And the excitement is, how do we bring value to otolaryngologists? There are revenue streams that we want to unlock for our otolaryngology members. It's not about me, it's about our members. How do we monetize your knowledge base and your all value to drive member value back?
Look at our members. Tell them what they should be excited about as an otolaryngologist in 2025.
Gosh, there's so much to be excited about. Who takes care of newborns to geriatrics to dizzy patients to surgical patients? We are experts in the head and neck. There's never been a better time to be in medicine, in otolaryngology, in our specialty. Because in uncertainty, Gene, comes opportunity.
Absolutely.
So I don't want us running away. We're going to embrace it. And the academy's your home. I take phone calls. I take emails. I reach out to you all. Send me your ideas. I'm going to steal every one of them. I will give you credit, but we're going to help you all in the future of 2025. Gene, we always have a way of ending these. We can do a pound out. I don't know. What do you all do at MUSC? What do you do in South Carolina? What's a Clemson? I mean, somebody taught me like hook 'em. There's a lot of that's Texas.
Yeah.
But I don't know. What do you all do here? What do you say here other than Southern hospitality? You've been so gracious to have me. How are we going to send this one out? You're president-elect. You want to send this one out for us?
No, I'd just like to say, thanks for coming to Charleston.
Yeah.
I think it's great to have you. I think that you bring an excitement into our organization. And I think that our organization is such a key for the specialty going forward. I appreciate you being here and coming and making the time to visit.
Yeah, and we're going to send Bacchus the bill, Doug Bacchus.
Absolutely.
All right, you hear us. Thank you all very much. Thank you, Gene, for our longest podcast and one of our most exciting. Thank you, Dr.
Thank
Brown.
you so much.
Thank you.